My name is David Armstrong, and I'm the Director of the Health Workforce Technical Assistance Center. And today's event is entitled Physicians as Shock Absorbers, the Structural Sources of Discontent in Medicine. I'm going to go ahead and hand things over to Janette Kaufman. Janet's the current chair of the Health Workforce Interest Group at Academy Health, and I believe she has a few announcements. Janet?
Yes, I do, David. Thank you so much. I think many of you are members of our interest group, but if you're not, this is an interest group that members of Academy Health can join free of charge. Our mission is to improve health and healthcare by promoting research and disseminating evidence that informs health workforce policy and practice. So if you're an Academy Health member and you haven't already joined, please do. And also feel free to if you're join the interest group, use our listserv to share information. This could be information about webinars you think people or conferences maybe people might be interested in, job opportunities, postdoc opportunities. We really want to encourage folks to use it. For more information, you can contact me or you can contact Zhao Chu, who is our vice chair and is a senior researcher at the Association of American Medical Colleges. David, next slide, please. And for the interest group, couple announcements. The Academy Health Annual Research Meeting will be in Seattle, June 24th through 27th. And, we have a couple of activities that we hope you can join us with. There's going to be an informal gathering Saturday night at Pike Brewing, which is in the Pike Place Market. And we'll put information out on the listserv about this. But this is going to be in partnership with the University of Washington Health Workforce Center, which is celebrating a milestone anniversary. So please join us for that Saturday. We're going to time it after the main Academy Health reception. And then on Sunday, the 25th at 11 a.m., we will have our interest group meeting. It's going to be one of the concurrent sessions, and we're going to continue talking about a lot of the themes that we're going to talk about today. Thank you, David. Our title is Healing the Healers, Strategies for Alleviating Burnout Among Healthcare Workers. And we'll have three colleagues, Deborah Goldberg from George Mason University, Patricia Pittman from George Washington University, and LaTanya Trotter from University of Washington, who will be presenting their work on burnout. And we are working on, we're not sure if we can pull it off yet, but having a reactor representing the healthcare workforce and one from healthcare employers. So stay tuned for more information about that session. With those announcements out of the way, we'll move on to today's session, and I'm going to introduce our moderator, Professor Janette Dill, who is Associate Professor in the Division of Health Policy and Management at the School of Public Health at the University of Minnesota. She's also a member of our advisory group for the interest group, which is a way if you really want to be super involved in what we're doing. And over the summer, you'll have a chance to volunteer to be part of the advisory committee. And so Professor Dill has done workforce research in a variety of areas. Current projects include regional variation in supply of direct care workers, racial and gender disparities in rewards for professional certification and unionization among direct care workers. And she's also affiliated with the Public Health Workforce Center at University of Minnesota. So with that, Janette, I'm going to turn it over to you to introduce Dr. Tania Jenkins, our speaker for today.
Thanks, Janet. I know it's confusing, Janette and Janet. And I would recommend, if you're interested, joining the advisory board. It's a great way to get to know other workforce scholars at Academy Health. So we're really lucky to have with us today Tania Jenkins, and I'm going to go ahead and introduce her. Tania Jenkins is an assistant professor at the University of North Carolina, Chapel Hill in the Department of Sociology. I'll also mention that is where I did my PhD, and so I'm alum. She is also a faculty member or faculty research fellow at UNC's Sheps Center for Health Services Research. Her research interests include medical sociology, medical education, work in professions, ethics, and qualitative methodologies. Her research has been funded by HRSA, NSF, as well as the Canadian Institutes of Health Research, and has appeared in journals like the Journal of General Internal Medicine, Advances in Health Sciences Education, and the Journal of Health and Social Behavior, among others. She's also the author of Doctor's Orders, The Making of Status Hierarchies in an Elite Profession, and her current research focuses on the extra-individual or structural factors shaping career satisfaction and well-being among physicians and trainees. So thank you so much, Tania, for being here today. We're really looking forward to your talk.
Thank you so much for that really warm introduction, Janette. It's always wonderful to see somebody else, a former UNC alum, in different spaces. Can everybody see my slides okay? Just want to get a quick, excellent confirmation. Wonderful. Okay, so before I sort of, let's see here. There we go. Before I launch into the gist of my talk, I do want to begin by making sure to thank not only my funders for their generous research support, in this case, HRSA, but I also want to thank several colleagues, as well as, of course, my research subjects who unfortunately have to remain unnamed, but who were absolutely instrumental in making this project possible. So I want to thank everybody for their assistance and feedback. Great. So as is probably not a surprise to anybody on this call, physicians are a high-risk group for mental health, mental illness rather, and work-related stress. So despite having better physical health outcomes than folks in the general population, physicians have significantly worse mental health outcomes. That's long been true compared to folks in the general population, as well as other professionals. They also have higher rates of burnout. So prior to COVID, approximately 1 in 2 attending physicians and anywhere between 45 and 60% of residents were burnt out, according to sort of the estimates nationwide. Now, during COVID, burnout rates increased by as much as a third. And a recent survey has found that burnout and depression has actually been found to be worse in 2022 than it was in 2021. The latest Medscape physician suicide report found that almost a quarter, so 1 in 4 physicians reported that they're depressed. And that's compared to 15% of physicians reporting depression 5 years ago. And 1 in 10, that's almost 10% of physicians, said that they'd had suicidal thoughts. Now, just by comparison, nationwide, the prevalence of suicidal ideation is roughly 1 in 25 adults having had serious thoughts of suicide, so significantly higher among physicians. So perhaps unsurprisingly, there have recently been growing talk of a mental health crisis among physicians. Even Jack Resnick Jr., the president of the American Medical Association, very recently called burnout a health crisis for both doctors and patients, and noted that the problem demands urgent action, particularly because burnout and stress, aside from, of course, being detrimental to physicians, has also been known to contribute to preventable medical errors, increased bias in healthcare, as well as unprofessional conduct. So perhaps appropriately, research on well-being in medicine has increased substantially in recent years. But much of that scholarship, at least historically, and by historically, I mean the first 5 of the last 10 years, I would say, really has largely emphasized individual level causes and interventions. And I want to, make clear that I think some of these interventions are very important. It's important to offer an individual who is struggling resources. But at the same time, sometimes these interventions, especially when used alone or in isolation compared to other approaches, they can overlook the underlying structural factors undergirding satisfaction and well-being in medicine. And they can go so far as to even harm physicians who feel individually blamed for their discontent. Now, just to make sure we're all on the same page, I've used a couple of terms in the last few sentences that I really want to make sure I unpack. So first, I'm using the term physician's discontent, putting discontent in quotation marks, very broadly in the way that other medical sociologists have. This is a term that is used in the med social literature. And so I'm including in that term dissatisfaction, stress, mental illness, and burnout, not just mere unhappiness among physicians. So I want to make that really clear that I'm using discontent in that specific way. I'm also referring to structural factors. So these are those extra individual social forces at the organizational, professional, and societal level that shape, enable, and constrain physicians' feelings about their work. Now, to understand, increasingly to understand where these social or structural drivers of burnout in particular are coming from, there have been a number of different calls in recent years. In 2019, the National Academies of Sciences, Engineering, and Medicine released a well-known consensus study calling for a systems-based approach to burnout. Most recently, you're probably familiar with the National Academies of Medicine and the Surgeon General's landmark reports dating back to 2022, calling for systemic solutions to healthcare worker burnout that, quote, shift burnout from a me problem to a we problem. There are significant unknowns that remain, however. So first is the role of professional level factors in understanding sort of how burnout is playing a role. So the first thing I want to say is that the National Academies of Medicine and the Surgeon General's recommendations were designed to apply broadly to healthcare workers of all types. And this is in part to be more inclusive of often overlooked allied health professionals in discussions about burnout. I argue, though, that in so doing, they may have inadvertently overlooked the unique role that physician-specific factors and physician-specific factors like professional norms and specialty cultures can have in shaping well-being. Second, and perhaps even more broadly and more deeply, the reports do emphasize system-level approaches and solutions to burnout, and they offer some syntheses of the current literature to support those recommendations. But few studies have actually considered how everyday structural realities work together in real time to create unhealthy work and learning environments. So in other words, there have been calls for systemic change without fully understanding how that system works in all its messiness and its complexity, with individual physicians working within specific healthcare organizations, which bring together members of a larger profession, which extends beyond any single organization, and that are located within a broader societal level healthcare system. And that kind of complexity, that kind of messiness lends itself really well to ethnography, which is a qualitative research method that involves the researcher immersing herself in a community and conducting observations and interviews to better understand community members' lived experiences. Now, ethnography can afford us a richer, more nuanced insight into how different mundane, everyday structural forces intersect with one another to create unhealthy work environments. Yet, with very few notable exceptions, few scholars of physician well-being have actually observed physicians at work. Now, for its part, and I don't want to dwell too much on sociological theory here, but you'll see why it's relevant in just a moment. Medical sociology, in theory, is really well positioned to examine how structural realities affect medical professionals, and particularly from a social determinants of health perspective. So sociologists will often use the idea of upstream versus downstream interventions to think about health, and they stem from a commonly used metaphor. Some of you might already be familiar with this. The metaphor is of a physician who sees someone drowning in a river. She rushes in to rescue the patient, administers CPR, calls an ambulance to bring them to a local hospital. And the physician is barely done, sending that patient, a drowning victim off in the ambulance when she sees another drowning victim. And she repeats the same procedure, jumps into the river, rescues the patient, puts them in an ambulance, and keeps doing that, so on and so forth, so much so that through no fault of her own, and of course it's important it's important to save folks who are drowning downstream. But it makes it incredibly difficult to look further upstream and ask, why are so many folks drowning to begin with? What is it that is leading to all of these drowning episodes? And is there something that we can look at further upstream in terms of social structures that may be contributing to health problems in the population. So looking upstream is often thought to address more of the root causes of a particular outcome. But back to physician well-being. So sociologists of medicine have carefully studied the effects of changing healthcare landscapes on over the last 50 years. So everything from dwindling public trust, rising bureaucratization in healthcare, increasing interference by third-party payers, all of these have been broadly described as countervailing forces by Light and other colleagues. So a lot of work has focused on how these countervailing forces have impacted the day-to-day practice of medicine. And a lot of debate has occurred within medical sociology over whether the broader profession of medicine is maybe in decline as a result of these countervailing forces, or whether it in fact remains dominant and authoritative over medical matters in the face of these countervailing forces. In these debates, however, medical sociologists have yet to examine the impact of these changing US healthcare landscapes, so upstream factors, on individual providers' well-being. So I asked, could it be that, in fact, both sides of this debate are correct, that the medical profession is undergoing massive challenges and has largely remained dominant over medical matters, partly at untold cost to physicians themselves, who must absorb the burden of increasingly conflicting demands on the profession? So in this paper, I draw on an 8-month ethnography in a pediatric primary care clinic to examine how contemporary organizational, professional, and societal level factors, all upstream, work together to shape physician well-being. And then I use those findings to propose a more general socio-ecological model for thinking about how macrostructural factors shape individual physicians' micro experiences. So to answer that research question, today I want to tell you the complicated story of a single clinic. This clinic is part of a larger comparative ethnography that I've been working on for the past several years within the realm of pediatrics. And I'd be happy to discuss further in the Q&A why I chose pediatrics as a specialty. The data collection took place at this particular clinic between December of 2020 and August of 2021. And of course, that temporality is very significant. The data were collected approximately a year into the COVID-19 pandemic. And so these were not exactly ordinary times at the clinic. But I argue that this proved helpful for me for 2 reasons. The first is that the pandemic allowed me to travel away from my home institution to do field work. And so it opened up a broader range of institutions that I could investigate and study. And second, by conceptualizing COVID as a kind of acute on chronic stressor, the way some have, it made visible some of the more mundane structural factors and processes that were going on already, but that may have been otherwise taken for granted or less visible during ordinary times. So that yielded new insights potentially into routine processes. So I spent 8 months over the course of that time period at an academic general pediatrics clinic, which I call Condor Downtown Pediatrics Clinic, or just downtown for short. Of course, these are pseudonyms to protect the confidentiality of my respondents. Now, being an academic practice, the clinic was affiliated to what I call Condor Medical College, which insulated it in many ways from the kind of financial pressures that a private practice might experience, for example. So that's one thing to keep in mind with my findings. When I mentioned the financial pressures experienced at downtown, these were actually less pronounced than they might have been in other settings. And downtown was located in a low socioeconomic status neighborhood where the median household income was 25% lower than the national median household income. Anywhere between 2/3 and 3/4 of patients were insured through Medicaid, whereas many practices will cap that at about 10%. It also served a very large Spanish-speaking population with complex health and social issues. So I spent 66 shifts observing in the attending and resident workrooms. I also interviewed 35 attendings, residents, and members of the clinic leadership. And among the 32 physicians in that sample, I administered the Maslach burnout inventory, which is a validated tool for measuring burnout, as well as a career satisfaction survey. I'm happy to talk more about my methods in the Q&A if there are any questions, but I am eager to get to my results. Starting with just some descriptive statistics of the sample. About 63% reported at least one symptom of burnout. So of the physicians who took the MBI, they exhibited at least one symptom of high emotional exhaustion, high depersonalization, or low personal accomplishment. 58% viewed their current work situation as a major source of frustration, and 39% felt that their medical careers had not met their expectations. 13% reported that they would not become a physician again if given the opportunity. So given these widespread burnout and dissatisfaction outcomes at downtown, the question is what contributed to the respondents' stress? And I asked them that, and I observed them in their everyday work. And I found that the pressures experienced by respondents really spanned the range of structural levels. So one way of thinking about this is to think of them as almost being nested within one another. At the societal or system level, they included broader social inequality and changing doctor-patient relationships. At the organizational level, centralized decision-making, economic pressures, and unresponsive leadership. And at the professional level, specialty cultures and unhealthy norms. So these are some of the factors that came up in my findings. I only have time to go into one example at each level today, just because of time constraints. And I'll mostly be focusing on the experience of attending physicians in today's talk. But again, I'm more than happy to talk about the totality of my findings in the Q&A. I also want to be sure to take some time to highlight the interdependency between stressors at different levels, because they often didn't exist in isolation of one another. Rather, they would reinforce each other, which again goes to the complexity of the system that physicians work in. So first, at the societal level, downtown pediatricians definitely had to contend with social forces that extended well beyond the four walls of the clinic, including treating social inequality. So during my field work, as part of a larger state initiative, downtown pediatricians were newly required to formally screen for social determinants or social drivers of health during well visits with school-age children. Now, many respondents felt that addressing social determinants of health was integral to being a good pediatrician, that it is part and parcel to the kind of work that they signed up to do as pediatricians. But it did add yet another task to already packed well child visits. So as attending Nina put it one morning, quote, "We have these new social determinants of health screeners that are wonderful for our patients, but now it's this whole thing that we have to look for, and I can't do it all." But doing it all was actually an apt way of describing downtown pediatricians' work. On a different morning, Nina entered the workroom at 10 a.m., which was almost a full hour after she had begun her first 15-minute appointment of that day. And she announced, quote, "So I just saw one of my longtime families that I've been following for several years. They've had a really tough time with food insecurity and loss of work. One parent had COVID this summer and was out of work for weeks. They sold everything they have. And now the other parent has to have surgery." So Nina said that she offered the family a bag of food from the clinic's pantry, adding, quote, "It's not much. It'll only last a few days, but it's something." And then she said, "It's all those social determinants of health that are so important." Now, she explained that she also spent a good portion of the hour-long visit helping the adult parent understand their upcoming surgery, which they consented to through an interpreter but didn't fully understand. So she says, so 15 minutes of my visit was dedicated to that. And when I asked whether she would get reimbursed for that time or could bill for that time, Nina chuckled and shook her head saying, "No, that's just part of the deal. A well child visit isn't just a well visit. It's all of this," she says, gesturing around her. "And so I have to deal with all that. Plus, I'm running behind now for my next appointments." So increasingly, downtown pediatricians felt like they were being asked to do ever more for their patients. Doing it all included doing more tasks, something that certainly seems to resonate with physicians across the country. Some of you might have seen this recent headline in the New York Times about a study published in the Journal of General Internal Medicine, finding that according to medical guidelines, physicians need a 27-hour workday. But it's not just the number of tasks. It's doing it all meant that it's not just doing more tasks, but also doing more difficult tasks, what some might even call impossible tasks, like addressing or fixing highly upstream social inequalities in health from all the way downstream in an exam room during a yearly 15-minute well child visit. And still, downtown pediatricians were expected to just absorb these demands and make them work somehow, which impacted their mental health. And that included the mental health of residents, of trainees at this clinic. Several were highly frustrated, like Jane, a PGY2 or second year resident who said, quote, "The problems that people have, I'm not going to fix them. I can't. There's not a lot that an individual person can do. And there's just so many public health things that need to be done," quote, end quote. So downtown pediatricians, in Nina's words, had to do it all. That is, push against societal inequality and care for their patients' physical as well as social well-being without having the requisite tools to actually address that inequality, which made some of them feel pretty powerless and stressed. Now, besides being asked to, quote, do it all, downtown pediatricians also felt that they lacked the organizational support to both meet their patients' complex social needs and their organization's high expectations. As one physician who left the practice explained, she said, quote, "It was impossible to be productive based on the setup of the place. It was impossible to be successful." And nowhere was this more visible than in the pressure placed on physicians over patient volume. And that pressure came from Condor, the overarching institution. Pressure which, to be sure, of course, also stems from beyond that single organization to the broader fee-for-service reimbursement models that exist at the societal level. So I just want to draw your attention to how we're already beginning to see, right, how the organizational and societal level, it can be very interconnected in this way. Clinics affiliated to Condor Medical School were centrally evaluated by their visit volume and the number of open slots on any given day or week or month, and they were compared to other clinics nationally. So, as one clinic leader put it, quote, "If there are empty appointment slots, that drives our department leadership crazy. They just want us to fill those slots." The fact, though, that there might be more open slots available at a place like downtown because of an increase in what are called no-shows or patients not showing up to appointments was not factored into these metrics, as two attendings discussed one afternoon. They said, "With the population we serve, maybe their car broke down, maybe mom had to pick up a shift at work, or someone got sick," said Bernadette, one attending. And Genevieve nodded angrily, saying, "Things happen, but we're penalized for that." And so downtown pediatricians therefore had to absorb that penalty that Genevieve was referring to and somehow bridge the gulf between their patients' unpredictable needs or unpredictable lives, which were, of course, driven in part by those societal level inequalities that I just mentioned. And on the other hand, the organization's, in some ways, unrealistic demands given that reality. And so again, we see how those different levels intersect with one another. It wasn't just the volume demands or the socially complex patient population. It's how both of those work together to create a situation that is, quote, impossible to be successful in. And this took a toll on providers. So Nina said, quote, "It's stressful because it doesn't capture the complexity of the kids I see." And here she's referring to the emphasis on volume. "It's stressful in the moment to try to rush. It's stressful mentally because I'm anxious and anticipating the day." So this was yet another way that it was impossible for downtown pediatricians to succeed. The organization expected them to see the same number of patients or more sometimes as wealthier practices across the country. So that's an organizational level stressor, with little consideration for the added challenges facing downtown patients. So that's a societal level stressor, given that a lot of those challenges stemmed from social inequality. Instead, it was up to the pediatricians to absorb these challenges and just somehow make it work, which had real consequences for their well-being, as Nina points out. And this is partly because that's what physicians do. They are trained and selected to be high-achieving, selfless, and limitless professionals. So one afternoon, 2 attending physicians summarized this ethos for me in the workroom, with one of them saying, Tania and I were just talking about this, the constant giving of ourselves. And a second attending nodded, saying, give, 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 to kind of summarize that ethos. And the first attending continued, quote, we have to serve ourselves up to the greater good at all times. So in other words, physicians are being asked to do it all by organizations that don't set them up to succeed, within a profession that tells them to give, give, give. So we begin to see how these levels start to work together and exacerbate one another. Now, this give, give, give ethos was especially true in the field of pediatrics, where the expectation, according to my respondents, is that everyone is friendly, warm and fuzzy, collegial. And conversely, if pediatricians were to push back or were not as warm, they were sometimes penalized. So with attending physicians, this sometimes took the form of being referred to as a squeaky wheel, whiny, or excessively negative. Residents would also get punished in evaluations for not being, quote, bubbly enough. So this was in the context of an attending explaining that there would be regular meetings to evaluate residents' performance. And during those meetings, the attending said that other attendings would report that, quote, it's not as pleasant to work with so-and-so anymore, referring to a resident. They just don't engage in conversation. And then this attending who's speaking to me says, I would ask, is the care in the room being blunted? And people would say, no, it's just the way they're coming off is not as happy to be here. I should note that these conversations would often happen around residents in their second year, which was known to be a very difficult year of training. And this same attending went on to note the gendered nature of some of these negative comments or negative feedback, that they were often they would more often apply, the lack of bubbliness comments would more often apply to female residents compared to male residents. So specialty-specific cultures like this one in pediatrics shaped how pediatricians felt they could express their frustration, which took a mental toll on respondents. As one attending put it, quote, they tell us to speak up and share what's on our mind, referring to the departmental leadership. But when we do, we're shut down. It feels psychologically unsafe to be here. Now, I want to point out that pediatric culture doesn't exist in isolation. It is embedded within the larger backdrop of medicine's often unforgiving professional culture more broadly, what attending Grace called, quote, a professional world of judgment, which discourages physicians from showing signs of struggle in any capacity oftentimes. And these professional expectations can amount to a type of superhero norm whereby physicians push aside human needs to avoid being perceived as lazy or selfish. Like in the case of Aisha. Aisha was a first-year resident or intern who recounted being chastised by a more senior resident for taking water breaks between clinic patients. She said, quote, that added a good amount of extra pressure, just feeling like I'm being watched, and that even if I take a couple of moments to drink water or check my phone before seeing my next patient, that I'm going to be harshly judged or assessed poorly for being inefficient just because I needed a couple of human moments. I again want to point out here that this pressure didn't just come in isolation from a single senior resident. This pressure was shaped likely shaped by, again, volume pressures at the organizational level to see more patients in less amount of time, which are, as I've already pointed out, shaped by broader societal level factors, including fee-for-service, reimbursement schemas. So again, all of these levels are interconnected in this way. So put together, what I found was that pediatricians felt they had little choice but to individually absorb these multi-level pressures and just keep going, sometimes at the cost of their own well-being. And in many ways, the organization, the profession, and society counted on them to do this. As one respondent said, quote, "I feel like we're treated like a limitless resource." In some ways, we can conceptualize them as the shock absorbers, serving as healthcare's suspension system, if you will, having to convert countless and in some cases impossible structural demands into competent clinical care at considerable cost to their own well-being. As another attending would frequently repeat around clinic almost as a mantra, "It's not our fault, but it's our problem." I want to share a poignant example of the health consequences of this type of shock absorption that emerged during an interview with an attending who recounted experiencing a personal medical emergency. This attending said, quote, "I blamed my condition on how hard I was working and then became emotional during the interview, saying, I felt like if I hadn't been pushed so hard, I would have taken better care of myself because I kind of blew off having really high blood pressure and other symptoms. I was just like, I'm fine. I have to work. I remember when I had to go to the hospital, I was like, I can't be admitted today. I have clinic tomorrow. I told my husband, you have to go and get my laptop because if I have to be admitted today, I have to tie up some loose ends. I can't do this." And he was like, that doesn't matter. And I couldn't recognize it because the culture at downtown was very not like that. Now, it may be tempting to interpret this example as just another workaholic physician who really ought to prioritize self-care, maybe do some mindfulness meditation. These are all fine solutions if the problem lies exclusively with the individual. But behind this physician's reactions are strong patient consumerist expectations to see their own physician, not a replacement physician if that doctor has to call in sick, along with complicated organizational logistics that made canceling clinic impractical, the same complicated pronounced volume pressures that we've already talked about, an organizational culture that didn't prioritize physician health, and deeply internalized professional norms to ignore bodily needs and give. So by their own account, these were the factors that led this physician to face a possibly preventable medical emergency, an event that deeply impacted their emotional well-being, which they described to me in interviews as, quote, really unhappy. So by over-relying on physicians to take on the multi-level pressures of modern healthcare and somehow just make them work, physicians are getting sick by and of their jobs. Now, to be sure, I want to be clear that physicians don't work alone to absorb these pressures. They work with teams of healthcare workers to help care for patients, to keep volume up, et cetera. But they are at the top of the professional hierarchy. And that means that they ultimately feel responsible for making things work. In one attending's words, quote, "The weight of that responsibility, that it's all on me to do this, the crushing feeling that I'm responsible is really unsustainable. We are, in fact, a finite resource." So in conclusion, I found that individual physicians and trainees were expected to meet, absorb, and surpass increasingly impossible, sometimes conflicting structural pressures from their employers, from healthcare systems, patients, even their own profession, where the norm is to work selflessly without showing struggle. So that right there underscores the importance, I believe, the important role of professional specific factors in shaping some of these outcomes. I argue that ethnography can help advance our understanding of physician discontent by shedding light on how these conflicting pressures work on a day-to-day basis to exacerbate one another in real time. So, for example, previous survey studies found that the ability to meet patients' social needs is correlated with physician burnout, much like I found. But these studies fail to capture the synergistic nature of physician stress or physician sense of responsibility for resolving these problems. It's not just failing to meet patients' social needs. It's struggling to do that while also struggling to meet really high organizational demands, while, oh, by the way, remaining bubbly enough to meet professional expectations. In the respondent's own telling, contending with such pressures and processes creates stress, tension, and unhealthy work conditions. As Nina said so poignantly, I can't do it all. And yet that is exactly how pediatricians felt, or exactly what they felt they had to do single-handedly to make it all work somehow. So rather than organizations structurally adjusting their volume expectations to accommodate heightened societal demands, for example, or societal expectations shifting to better align with organizational realities, instead, physicians are implicitly being expected to resolve these structural tensions individually at great personal cost to their health. I found that physicians regularly have to dampen the impact of everyday conflicting structural demands to keep the healthcare system rolling, much the way a car suspension dampens bumps to keep the tires on the road. Again, they don't do this alone, but the proverbial buck stops with the dock, which only heightens this pressure. And so perhaps put this way, it is perhaps little wonder that physicians are now currently facing a mental health crisis. It also raises sociological questions about how long the profession as a whole can remain dominant over medical matters if it's at the expense of individual physicians' health. I just want to end very briefly with a few sort of policy implications. I think if there's nothing else that you take away from my talk today, it's less the findings and it's more a different way of thinking about physician well-being that likely transcends this particular clinic. So the findings support a more general theoretical model of that we may be able to apply to other settings, a model that situates individual physicians within specific organizational contexts, a larger professional field, which extends beyond the confines of any single institution, and finally, a broader social system and global context. So my hope is that it is a model that can be applied to a range of different contexts in order to better understand what is going on systemically at the system level to shape these outcomes, and in turn, what could be done in order to improve those outcomes. So I'm going to stop right there and happily answer any questions you may have.
Thank you, Tania. That was great and so interesting. So I'm going to start off with a question about why you chose pediatrics and why did you choose an academic medical setting? Sort of what was your motivation for the particular setting that you chose?
Yeah, thanks for asking that. And the question of why pediatrics came up early in my research. Of course, I actually spent a long time wrestling with which specialty to look at. And when I first started this project, someone, I think, well-meaningly asked, why are you studying discontent or burnout or stress among pediatricians? They're some of the happiest people on earth, right? And in fact, it is true that general pediatricians historically have ranked among some of the happiest physicians at work, despite being among the lowest paid specialties. But in the last decade, the rates of burnout and dissatisfaction with work-life balance have doubled in pediatrics, with more than 3/4 of general pediatricians reporting burnout in 2021. So that's more than 75%, and that's up from 35% in 2011. So a significant increase, and less than a third reporting satisfaction with work-life balance, and that's down from 60% in 2011. So there are changes afoot in pediatrics. Pediatricians also have experienced a lot of the countervailing forces that I alluded to earlier, things like growing patient skepticism, certainly in the case of vaccine hesitancy. Increasingly, pediatricians are being asked by the American Academy of Pediatrics and other bodies to address social as well as clinical determinants of health within primary care settings. And they're being asked to do this within a context where state-based Medicaid programs, which cover anywhere between 1/3 and 1/2 of all children across the US, offer reimbursement rates at about 2/3 the rate of Medicare and just over half the rate of private insurance. And so in terms of a case study for thinking about how countervailing forces are shaping the lived experience of providers, I think at a national level, pediatricians are being asked consistently to do more with less. And so that's the reason I chose pediatrics.
Great. We have a number of questions in the chat, or in the Q&A, I guess I should say. The first is one of my former mentors, Bob Conrad, and he asked, do you think that the addition of PAs and NPs to primary care practices, where physicians are the least at
least the nominal supervisors?
Nominal, okay, you see it, yeah, of the non-physician providers might increase or diminish the pressures that you described?
Yeah, great question, Bob. And I think it is challenging. There's a couple of things that come to mind when it comes to mid-level providers like PAs and NPs. First of all, yes, I think absolutely adding more people to, if we think about sort of this being about a lot of pressure coming from a lot of different directions aimed at physicians, having more people to spread out the work, I think is definitely key. I think other specialties outside of primary care do this rather well. There can be a really good division of labor whereby physicians are able to share some of the workload with their allied health colleagues in a way that I think makes things run more smoothly. One of the challenges, of course, is the cost associated with adding additional providers, and to some extent, the challenges for physicians of having more folks to supervise and oversee. So I think in thinking of how my respondents might think about this, part of the answer would be, are they going to create more work effectively, right? Is it going to be more of me as sort of at the head of as kind of the ambassador, if you will, of the medical team, having to chase after more folks to make sure that things are getting addressed? And so, yes, I think it can help, but I also think that there are complications that have to be taken into account. And that's really where this type of approach can be useful, is sort of thinking through the what ifs. If we change this, what might that then lead to?
The second is also from a colleague of mine, Kyla Woodward. She says, thank you, Dr. Jenkins. I so appreciate the systems perspective. I'm wondering what your thoughts or those of your participants are on feasible and approachable next steps to work on these systems issues.
Yeah. So next steps are in terms of sort of solutions, I think those are really tricky. And I think that, like I said, if there's one thing that I hope we can take away from today's discussion is thinking about the interdependency between these layers. So, for example, the National Academies of Medicine report from 2022 makes a perfectly reasonable suggestion, which is to make sure that healthcare workers have paid sick leave, right? That there is a mechanism for them to take time off in order to take care of themselves and come back and do the work that they need to do. Now, from that perspective, yes, it would solve the logistical problems associated with sick leave at the organizational level. It would not necessarily, at least not immediately, change the kind of deep-rooted professional expectations that physicians experience to show up to work no matter what, even if they are sick. The number of physicians who told me that they would have to be dying to not come to work is astounding. And that came from all levels, from medical students all the way up to senior attending physicians. So the sick leave policy, like I said, initially wouldn't necessarily address that underlying cultural norm. It also would do very little to address, at least initially again, patients' consumerist desires, and understandably so, to see the physician that they signed up to see during their appointments. So I say all of this to say that it's tricky to think about, because on the one hand, there is a very reasonable desire to implement relatively easy to sort of institute changes, especially at the organizational level, that could make real difference. The problem is, I think we have to think about how those changes exist within this system that where sort of other factors are also at play. I did say a handful of times in my answer, though, that immediately that change might not happen. It is possible that if more healthcare organizations have in place systems of coverage and make it possible for physicians, for example, to take that time if they're sick, that with time, cultural norms within the profession, as well as societal expectations of physicians, may well change. But there will be a growing period where logistically this problem might be resolved or at least addressed in certain ways. But culturally and societally, there will still be those pressures.
One thing that surprises me routinely is how I would say behind many other industries, the healthcare system is in terms of providing maternity leave. I think they often provide sick leave, but maternity leave is one area where they really lag behind many other industries.
Agreed. That was actually also a finding for me. And in pediatrics, no less, where, I think there is it's a field where there is a deep understanding of the importance of spending time with, with a child shortly after birth. And so I think that also factors in to some extent, that there is a sense of frustration on behalf of the field, that we know that this is important and yet it's not happening.
Yeah, absolutely. Yeah. All right, let's see. The next question is, what do you see as possible solutions for individual physicians struggling to manage within a system that is constantly pushing to see more patients in a shorter amount of time?
This is difficult because the question in some ways is asking, what can an individual do in the face of these massive structural difficulties, right? And so there's a mismatch there that I just want to acknowledge. And I think that it's common, I think, societally, for us to expect individuals to address those structural factors, when in fact it is extraordinarily difficult for a single individual to resist those factors. I think so that's where, ultimately, what a single individual can do within that system is going to be more limited. I think, though, that first of all, sort of folks working together and thinking about how they might be able to collectively exercise agency and say, hey, this is an issue that we're all encountering, and we need to affect this type of change in order to make our lives more tenable, I think is one potential avenue. The other thing I'll say is that, and this is, as I mentioned, part of a broader study that involved a comparison of a number of different clinics. The thing that I noticed was that the folks who were able to exercise the most amount of agency, and by that I mean were able to take their careers in directions that made them happier, or were able to sort of make a change somehow in their work conditions, in their career, tended to be the least burnt out. So there is something to be said about being able to make changes to one's experience that to bring that experience more in alignment with what you would like it to be, that can be really powerful in terms of the mental health implications. The difficulty is being able to make those changes. And there are a number of structural factors that I wasn't even able to get to in today's talk about why it is difficult to do that.
Let's see, next question. Thank you for this. Did you see, and if so, can you describe different strategies or perspectives that some providers used and seem to cope better with what seems like an untenable solution? So you're sort of talking about how some providers took more control over their careers and then were happier and less burnt out. What were some ways that physicians were able to do that?
There were a couple of ways. I think some physicians, I mentioned that this was an academic practice. So, one of the things that made this in some ways a unique practice was that physicians were able, to some extent within many limitations, able to titrate the amount of clinical time they had versus research time. And so initially, a person who might have been very heavily clinical and maybe wanted to make adjustments and spend less of their time in the clinical world and more time in the research world were successful at doing so, and were successful rather at reducing their stress. I think another coping mechanism that some people had was, some of the respondents I spoke to worked part-time and were able to sort of reclaim their time in that way and put limits on how much time they were spending at this clinic. Again, this is what I mean by it. These are not solutions that are available to everybody. If you're not a clinician scientist and can't do research time, if you cannot afford to work part-time, if you cannot afford to leave this clinic for various reasons because of the job market or the benefits that come with this particular job, it can be incredibly difficult to pivot to something else. And that can contribute, I think, to physicians feeling trapped.
Mm-hmm. Mm-hmm. Let's see. The last question in the Q&A is there evidence that where professional bodies behave more like labor unions, that conditions might improve? What better collaboration between primary care specialties might have more benefits? Obviously, the AMA is sort of like a labor union, but interested to hear your thoughts.
In some respects, the other thing I will say, and I hope that this came through in my findings, is that the findings that existed at this particular clinic won't necessarily translate to all clinical settings or all specialties. What I can share is that part of this study actually, yes, looked at general pediatrics. It also compared the experiences of general pediatricians to pediatric surgical subspecialists, which are situated in a completely different space with regards to sort of, if we think of the professional hierarchy, they exist in a completely different stratosphere in some regards with respect to, the funding that surgeons bring in and the kind of professional respect that they are often afforded. So I don't know that a labor union across all medical professionals would make sense, because I think all medical professionals, again, are not only sort of bound by broader professional norms and things like that, but also bound by different organizations and occupy different spaces within those same organizations. So instead, I'm intrigued by what Bob is saying here about the idea of collaboration between primary care specialties. I think that, there's a lot more in common, I think, between in some regards, between the general pediatricians I observed at downtown and what I imagine is the experience of the family practice physicians down the road and the internists as well, right? And so I think there is something to be said again about thinking about collective agency and about physicians working together to use their voice and their power as a group in order to affect change.
Well, we are down to the last minute. So this was really good timing in terms of the Q&A. So I want to thank everyone who participated today. Thank you for your excellent questions, and especially thank you to Tania for your awesome talk and for giving us a little bit of your time today and sharing your research. My next question was going to be to ask what's next. I don't think we have time for that, but we will watch for what's next in the future. Thank you again.
Thanks so much for the opportunity. This was wonderful.
Yes, thank you so much, Tania, and folks who are going to Academy Health Annual Research Meeting, look forward to seeing you there.
Definitely. Have a good afternoon, everyone. Thank you.